It is so great to be back with you again this year. I'm delighted to share this stage with some incredible people and to honor you in the work that you've done this past year. First of all, I wanted to recognize that not everybody at this symposium is in the room. For the first time, we're doing a webcast to make sure that all the hospitals in South Carolina, and even many beyond the state, are able to join us for parts of the program. So as I welcome you physically here, I also want to acknowledge that we've got people who are with us virtually from all over the country, and welcome them. I want to start by congratulating you on the safety progress that you've made since I was here last year. It's really impressive to see what can happen when physicians and nurses, when healthcare executives and leaders, when patients and family members come together in a room like this and plan and then go back and execute. And so my sincere congratulations to you on the progress that you've made. It's really impressive. And then I want to push you a little bit. So this year will be a new challenge for you, and that is really to think about health and healthcare in a different way. As I stand up here this morning, I was thinking about the challenges that we face here in the United States and thinking about how difficult it will be to come together and keep the promises that we make to patients at a time when reimbursement rates are being decreased, when lots of resources are shrinking. And I was thinking it's a big challenge. And then I turned on the news and I saw what's happening in Japan. And I thought our challenges are nothing. And I thought maybe we should start today by thinking about how lucky we are and sending some warm prayers off to a country that needs our thoughts, attention, and support. And so I ask you just to take a moment of silence and think about what we have here with gratitude and what we can send in terms of sympathy and love to another country desperately in need. So thank you for that. As we think about today, I'm going to ask you to be thinking about taking on some new challenges. You've really created an amazing infrastructure for safety. And now I think it's time to think about the triple aim, the IHI's triple aim, which is improving simultaneously the health of a population. In your case, you've got the state of South Carolina. Improving the processes of care, the care delivery, and at the same time controlling cost. It seems like a daunting challenge, and yet I am delighted here to think about what you've done in coming together and taking on this pioneering challenge. I believe that the triple aim is really going to transform healthcare. When I first started as a hospital chief executive, I was thinking about bits of the triangle, but not all. And as I've traveled the country and spent a lot of time in healthcare systems, I see people saying, I'll take on safety, or I'm a public health person, or I'm a finance expert. But rarely could I find an organizational leadership team that said, I will take ownership of all three of those elements of the triple aim, and that's what I find here. I think that this is a unique collaboration that a number of South Carolina organizations, including the sponsors of today's Patient Safety Symposium, are coming together to say, we'll not only make continuous improvements in safety, but we want to take on that triple aim. I'm really pleased and honored to announce a dynamic new example of a statewide collaborative today, the South Carolina Partnership for Health. And I'd like to invite Thornton Kirby from the South Carolina Hospital Association, Jay Moskowitz from the Health Sciences of South Carolina, and Jim Daling from Blue Cross Blue Shield to join me on the stage and have everybody honor this new partnership that says we together can improve the health of the population of South Carolina, the safety of our patient care, and drive down and hold cost per capita. So I'm delighted to bring you up onto the stage and make this commitment nationally known. Jim.
Thank you, Thank you, Maureen. First, let me just congratulate each of you in attendance at this very important symposium today. You understand and appreciate the importance of patient safety And I'd like to congratulate the Hospital Association for their continued leadership at this conference. We heard Jim O'Loughlin in his opening remarks say that South Carolina was recently ranked by the Agency for Healthcare Research and Quality as one of the 5 states making the greatest improvements in quality and safety in healthcare. That doesn't just happen on its own. It happens because people like you, like your organizations, and others have embraced the challenge to improve patient outcomes. We're making good progress, and these are very exciting times. But there is still much to do, and to that end, I'm pleased to say that Blue Cross and Blue Shield of South Carolina, the South Carolina Hospital Association, and Health Sciences South Carolina are announcing that our organizations have come together in a collaborative way to form the South Carolina Partnership for Health and are committed to furthering the ideals of the Triple Aim. We'll be working together to identify and implement targeted initiatives based on research results and best practices to improve the safety, quality, and cost effectiveness of healthcare services delivered in South Carolina. And I would also like to say that this isn't a first for us working together. We have formalized it now, but we have worked together with many organizations in this state over the past several years, including the Hospital Association and Health Sciences. We're excited about this new partnership and look forward to moving South Carolina forward as the national leader for improving patient outcomes and reducing unit costs. Thank you, and enjoy the symposium. Maureen?
So what an exciting time, and I'm really delighted to be here for the launching of this partnership. As I was saying, I think that it's the first that I know of to get everybody around the table and to set out some bold aims on this kind of work. So for a healthy South Carolina, our world still is filled with challenges. And I want to start by laying out some of those challenges for us. You've made incredible progress, and we still have quite a ways to go. I need to show this slide just to remind us that even in a time of cost constraint, we have lots of resources. Here, we compare the United States per capita spending with other countries, and you can see that we spend more than double the average per capita cost. And so there is lots there that we can do. And even still, we've got some safety problems that we can address. So we have high expenditures per capita, and we don't yet have the safest system. A lot of that has to do with the fragmentation in our system, which makes me even more joyous to sit here and celebrate the fact that you're bringing pieces of the system together in service of the Triple Aim. As we look at mortality amenable to healthcare, this is a statistic that demonstrates that there are still some places that the healthcare system can make dramatic improvements. Hospital-acquired infections or mortality in diseases that we know how to fix in children or in younger adults. And here we've got the challenges of healthy life expectancy compared to other countries. We're not doing as well as we could. So I'm laying out the challenges in the beginning to say that for adults in our country, and even for adults in the state of South Carolina, we can do better. And I think the Triple Aim may be an answer to that. Our infant mortality rates in the United States still vary widely from state to state, community to community, and I know we can do better on that. And recently, IHI and the Commonwealth Fund just presented our first state scorecard for children. And here, I think the future of our population health is in our hands. We've got lots we can do here. This graph shows state by state the gaps that we see in children's health, both in current state and in the future potential for long and healthy lives. And sitting here, I know that all of you care very deeply about the health of the children in South Carolina, and it shows that we've got some work to do here. This is an example of state hospitalization rates for children with asthma, and you can see how much variation there is. There's lots to learn from the best, I think, in terms of living conditions and understanding the whole of the child's life experience, and lots of gaps we can close, again, by working together. We've also got normal population trends, like the aging of the population. And you can see that the number of people who are 65 and older is becoming greater and greater a part of the population. So we've got normal aging and chronic disease on top of some healthcare system problems. And I was looking at this trend in obesity as an example that started back in 1985 with some population mapping about states that had a high percentage of people with obesity. And as you can see, as each 5-year increment rolls around, we ended up having to add more and more colors to the map by showing that more and more of the state's population is in the obese categories. And as I looked through that gradual shift, not gradual, it seems very rapid shift of obesity rates across the country, I realized that that didn't happen in my lifetime. That happened in my son's lifetime. That change happened in my son's lifetime. So we've got to do something, I think, in adapting and adopting the triple aim to start to work on the population health. That's our obligation, even as healthcare providers, to shift our focus to begin to work with the healthcare, the population health and public health teams, and to create a new sense of what that triple aim can mean for all of us. So we end up with this choice. Should we be thinking about cutting cost, or should we be thinking about rationing care? And my belief is that we need some new designs. We need some new eyes. And that's what you're going to experience in these 2 days. You're going to see new ideas from all of the presenters. You're going to learn new ideas from each other at coffee breaks and at dinner. And I hope that you'll go home with some real potential new designs that you can implement to solve some of these problems. I love this quote from Albert Szent-Györgyi. Discovery consists in seeing what everyone else has seen and thinking what no one else has thought. And I think that's the theme for these days, is really coming up with some new designs that are going to improve the care that we deliver here in South Carolina. Every year for Christmas, I give my family, their Christmas present is a trip. It's a trip and it's an adventure. And the good thing about it is, so when they open their Christmas presents, there's something in there that symbolizes the trip that we'll take during that coming year. And the good thing is that I get to plan it and I get to go on it. So that I would really recommend you think about this kind of a Christmas gift for your family. But recently I took my family to Bhutan, and I asked to go to the hospitals. And so I was visiting the hospitals. They said, do you want to go to the East hospitals or the West hospitals? And I went to both. But in the East hospitals, I saw many run charts and control charts, statistical process graphs, and you could actually see much more quality improvement in the Eastern hospitals than you could in the Western hospitals, which made me think that there's lots of work to do. And then I went and visited schools, because I'm really interested in how we create self-efficacy and a sense of possibility in our young. And I went and spent a couple of days touring schools, and I was walking out of an art school. Can you understand me, my Boston accent? It's one of my problem words, art. But anyway, I was walking out of an art school, and I ran into this woman. The interesting thing about Bhutan is that every adult needs to wear the national dress. So every man and woman walking through the streets wears a national costume whenever they leave their homes, and yet they all speak English. So I went up to this woman in this beautiful national dress, and I said to her, can I take your picture? And I was talking to her about her art studies, and she said, of course, take my picture. And so I took her photo. When I came back, I was showing Don Berwick the pictures, and he started to laugh when he got to this one. And I said, why are you laughing? And he showed me that the book she's holding is entitled Quality is Never an Accident. So there I was in Bhutan in an art school, in a woman with traditional dress who's reading a book, Quality is Never an Accident, and I thought the world is really a small place. So here I'm going to ask you to think about the triple aim. How can you, in your roles, in your jobs, in your teams, when you return, think about the connections between the health of the people that you serve, the care experience when they're in your hospitals or your clinics or your offices, and how can you drive out cost? And I want to give you quick examples from each one of these, but to lay out the big challenge, which is the integration of all three. So let's start with the care experience. You've been working on safety with great effect. You are about the same size as Kaiser Permanente Northern California, and we started working with them, and you can see that they're tracking mortality rates across Northern California, and year after year they're saying, we annotate, we implemented change, annotate our run chart, and we're learning, constantly learning what's working, what's not working. But you can see this wonderful trend as they make improvements in care. We're working with Henry Ford, and here you can just look at their nosocomial C. diff rates. And again, as they introduce changes methodically, by introducing bundles of care and the like, as they're introducing these changes, they're looking at their C. diff rates drop. I would also point out, though, that there's the other side of the coin. You're seeing better care, but Henry Ford also did an amazing job of quantifying the savings that they're seeing within their system associated with the improvements of care. So as we're looking to deal with Medicaid rate reductions or other kinds of cost constraints, know that a lot of the money that you need to find and save is in right now the defects in care. So a very strong focus on improving care is also going to be helpful to the bottom line. So we've been working on safety, and I want to push you here in the experience of care to think even more broadly about what the experience of care means. I don't know how many of you have this taped over your desk, but think about all of the dimensions, all of the IOM promises that we've made to patients. And the way that I've been doing it, I go onto the New York Times, online, and I'm going to ask you to do this with me. I'm going to ask you to make a promise to me this week that you'll do a very brief exercise before the end of the week. And that is to go onto New York Times online, to hit on the health button, and then you'll see a page pop up and it will say patient voices. And I'm asking you to go into one of those diseases. There are about 230 little clips sorted by 34 different diseases, and watch one or two of those video clips. It will be 3 or 4 minutes each of your time. But what you will notice when you listen to those clips, it's about ALS, it's about having diabetes, every kind of disease you can imagine. And it's different patients with that disease talking about what I will call here the burden of the illness. They don't call it that. But what they're describing is what their whole life is like. They're talking about the impact of a fatal disease on very young children. They're talking about not being able to work and the financial constraints that puts on them. They're talking about pain. They're talking about disability. They're talking about the burden of the illness. And when you look at these little video clips, it gives you a wonderful perspective on what it is like to live with an illness. Not this gentleman, but another one with ALS. He's also very funny. He's got my accent, and he's wheeling his wheelchair around Boston, and he's talking about how horrifying it is to be a Bostonian with a disease named after a New York Yankee. So they're wonderfully spirited patients who are telling us in their words what it's like to have an illness, what that burden looks like. And then what I'm asking you to think about is, in a lot of cases, we can't do anything about the burden of illness, but we can minimize the burden of the treatment. And that's our job. In a lot of cases, we've designed care around us. We've said to the patient, can you come in and get your blood drawn, because when you come in next week to have your physical, I want to have those results in my record. But that's doubling the burden of the treatment on that patient. And if you just start to look at the burden of the illness, and then you start to really discover what a patient goes through in the treatment protocols, I think we can do a whole lot better. This example from Appleton, Wisconsin, I visited recently. It's a group of physicians who really decided to look at the burden of treatment. They're all independent medical practices. They didn't change their legal structure at all. But they were thinking about building a new building. And rather than building a new building and the independent practices occupying it, they said, well, what if we make it easier for patients? So they agreed in the new building that they would use a common registration process, that they would use a common lab system, that they would create a common patient plan. And then, rather than saying to the patient, come in because I need to draw your blood, and then come back in a week because it's time for your visit, they said, how long does it take a patient to walk in the front door of the building, get registered, get their blood drawn, go up to the independent private practice, and be in the exam room? And they trailed that, and I actually did myself, and they said that took 15 minutes. So they said to the laboratory, you have 15 minutes from the blood draw to get the results into the patient's electronic record, so when the physician walks into the room, the results are there. And I went and spent a half a day in the laboratory. They are amazing. They put all the machinery on cots, and they kept moving it around until they got exactly the right flow so that they could get 90% of the lab results into the record in 15 minutes. When the patients come in, and if they're seeing their primary care physician and he says you need to see a rheumatologist or a pulmonologist, all the physicians have agreed open access between the practices so the patient can go over and be seen that day. They can get their mammogram that day. So basically, it's care designed around the patient. And when the patient leaves the practice that day, they get one common medication record. All their medications from all their physicians are in one place. All their lab results, all their radiology results, and their entire plan of care. The physicians didn't give up anything in terms of legal independence, but they gave up everything in terms of design to minimize the burden of treatment. I think we can do this all over the state and really change the way patients experience care. At IHI, our research for the year is around this notion of if we want to improve clinical outcomes, we need to do better on the science, and we're doing lots of work on number needed to treat and creating some new ways to test which patients will find efficacy in which treatments. But we're also adding this notion of personal preferences, personal styles, and beginning to think about how do we make care better? How do we actually create a learning system so that we understand patients and their choices more accurately? I spent some time at Mayo Clinic this summer, and I made rounds with the doctors and the nurses, and I found how important that bottom square of patient preference is. In one case, I was sitting in a patient's room when a physician and a nurse were teaching the patient about a newly diagnosed diabetic. And now I've been in many exam rooms watching this happen in my career, and usually what you see is the physician will write a prescription and say, I want you to test your blood so often, and I want you to take 2 units of this and 5 of that, whatever. They'll give a prescription, and the patients will go home and try and figure it out. What I saw here is that there's a deck of cards, and the physicians and the nurse lay them out on the desk, and they say to the patient, these are the elements of caring for your diabetes. It's everything from there's going to be an impact on your weight, it's going to be cost, it's going to be how much at risk you are for hemoglobin A1C fluctuations and variations, how much of an onerous daily routine can you manage. And they lay out the cards and they say to the patients, which one do you want to focus on first? And in all the rounds that I was in, if you were a woman and you were newly diagnosed diabetic, they picked the weight change card first. And they said, oh, look, there's a drug where I'm likely to lose 3 to 6 pounds, and there's another drug where I'm likely to gain 4 to 6 pounds. I think I'll go with the losing weight drug first. And then oftentimes they picked cost as the second one, and they would say, well, the drug that causes you to lose weight costs $9 a day, and this other drug costs 10 cents a day. Well, that made some of the women immediately shift their plan. Some people who would travel for a living, they needed to incorporate the routine, the daily routine, into a very busy other life. And so through sorting these cards, each patient then came up with a plan, agreed with the physician and the nurse, that met their own lifestyle challenges. It's just an example. I also watched rounds on a patient who was being discharged after an MI. He was about 75 years old. And the physician sat with him and he said, I'm going to prescribe these medications, and these are the side effects. The medication costs $40 a month. I was so impressed that every physician and nurse I met with there knew the costs of the drugs. And I was really impressed with how often that made a difference to the patients. In this case, the gentleman said, it doesn't matter, I can afford that, that's not an issue. In other cases, they said, that's my monthly food allowance. I can't afford the drug and I won't be taking it. But when you don't have that conversation, the physician goes away believing that the patient is going to fill the prescription and take the drug. In this case, the physician was going through the daily routine, how to monitor and the like. And finally, the wife said to the physician, hey, doctor, she said, look at me. She said, he does nothing you say. He sits there and nods. He never takes his medication. He never does anything you say. If you have any hope that he's going to comply, look at me. The doctor turned his chair. He didn't say another word to the gentleman. He just turned his chair. The wife said, okay. The wife negotiated the daily routine, and I walked away feeling hopeful that that person had some chance of taking his medications when I've seen so many situations when the patient looks compliant and has no intention of stopping by the pharmacy on the way home. So this idea of really understanding the patient is critical to all of our work going forward. I would ask you to go back and look at a couple of videos. The next patient who you see, understand them more fully, understand their life more fully, their preferences. And really, I think we'll be able to have 2011 be the year of designing the voice of the patient into our processes. The second part of the triple aim's cost, and I just want to very quickly hit on cost. I know it's an issue here in South Carolina as it is all over the country. And I, in the past, used to feel like I was either in a room talking to people about quality, or I was in a room talking to people about cost. We can't afford that anymore. We've all got to work on this together. And I'm finding now CFOs are talking about central line rates, and clinicians are talking about cost per case. So I feel hopeful about this, but know that financial literacy associated with your care is, I think, a critical part of the professional equation going forward. So some of it might be using lean methods at Virginia Mason. They're seeing positive bottom line. They've come through both the recession and lots of market shifts at a time when almost every other provider in that local region around Virginia Mason has had a layoff or a staff freeze. Virginia Mason has not. And that's because they've used lean methods to drive waste out, which allows them the luxury of maintaining their staff, and I think that's critical. You can see here that a big focus of theirs was increasing the percentage of time that a nurse spends at the bedside. And in doing that project, like transforming care at the bedside, what they're able to do is minimize waste, put the clinicians back at the bedside where they want to be, and in doing so, decreases errors and harm and problems in handoff. Theta Care, again, back in Appleton, I watched rounds, and they call them collaborative rounds. So every patient admitted at Theta Care, within 20 minutes of the patient being admitted into their patient room, they're admitted by a team, a physician, a nurse, and a pharmacist. And the pharmacist actually takes the lead on the admission. The pharmacist starts by welcoming the patient, and the physician, the nurse, and the pharmacist review the patient's history, their medications, how they got to the hospital, their expectations and their wishes for this stay with the patient and the family. They together create a big plan, daily plan, hospital plan on a whiteboard, so everybody agrees on what's going to happen, patient, family, and care team. And what they found is this collaborative method has really decreased length of stay, decreased cost per case. The physicians and the nurses love it because once they get used to working together as a team, they find that it takes some of the hassle out of their daily work. They're not chasing each other. They're all on the same page. And they find that the patient satisfaction has dramatically improved. So what we're seeing is lots of organizations around the country working on what I call flow faults. It's all those, the collaborative care rounds is making the care process for that hospitalization much smoother. But I also visit hospitals where the nurse doesn't know when the patient is expected to be discharged. The patients have no idea. The family isn't ready. Or the patient is stuck in an ICU bed because there's no med-surg bed, stuck in an emergency department because there's no ICU bed. So when you start to think about flow and the impact on cost and patient satisfaction, I would ask you to think about the linkages between the care processes and the cost. One of the hospitals we're working with, Cincinnati Children's, started identifying these flow faults. They actually call them that. They measure that as a quality metric. The metric is, when is a patient stuck in a place they shouldn't be? And when you start to think about flow and you smooth it out using queuing theory, reliability theory, managing hospital operations, you can provide much better, smoother care for patients at a lower cost. If you go on to ihi.org, we've created what we call the waste identification tool. And a nurse or a physician can actually make rounds on a unit and through prompts ask yourself some questions. Does this patient in the right place at the right time? Are they stuck here because we're inadequately managing flow? And once you can see all of these flow faults, you can track them on a recorder, then you can aggregate those up and create kind of a plan for how to drive waste out of the system. It's an example of how I really believe our attention to using engineering sciences and using reliability theory can provide much better flow and care for patients and really decrease cost, optimize the use of our capital equipment. And then finally, I want to say a word about population health. I showed you in some of the early slides that in South Carolina, we still have a way to go on population health, both for adults and children. And so how do we begin to close that gap? I think and agree with Bill Doherty that the greatest untapped resource we have in healthcare is the wisdom and the energy of patients and families. So how do we listen to them? How do we bring them into the care planning process? At IHI, we're doing some research in looking at correlations between socioeconomic indices and health. And what you can find is that pretty reliably, the poorer counties in a particular state have the worst health. So every now and then, this is Louisiana, and every now and then when we look at a state, we find this outlier, this community, this county where the socioeconomic status is poor, but the health is better than we would predict. And so we're going into those counties and studying what is it about this county that's creating efficacy or a focus on health, or maybe it's some different way that they're thinking about it. We don't have the answers yet, but there's some really interesting lessons for us to think in this area. Here's your South Carolina state, and you look pretty much as you would expect, aligning socioeconomic status with health, but there are a couple of places we might explore to learn some lessons there. And I think that it's really trying to understand that our goal at IHI is how can we pull the counties down? So if we can't necessarily do something about socioeconomic status, how do we still then improve health? And so our goal at IHI in the coming year is let's pull the counties down to better health. And we're finding some great lessons from around the country and around the world. I do a lot of work in Jönköping, Sweden, and they take a very broad view of health. When I'm there, they have community projects, as an example. When I in Jönköping teaching, I'm often teaching a group of elderly people who come together once a week, and they all say, this is my PDSA cycle on weight management this week. This is my PDSA cycle. And all of them know the model for improvement. They all carry control charts and annotate them, and you should see their health getting better and better. In Jönköping, they've implemented walking school buses. So instead of the bus pulling up, the driver, so to speak, walks up and picks up each kid, and the drivers are in great health now because they're walking the kids to school. The kids are learning early on that walking is better. But every place you go, the hospital cafeteria has amazingly healthy food. So they've taken this global view of health, and I think that might be one example. complicated slide from our work in the South Central Foundation in Alaska. But here, the NUCA program is focused on children 0 to 5. There's a very strong belief from their work in Alaska that if you can get a child healthy at 5 years old, you have now charted 70 more healthy years. And if you don't pay attention to that 0 to 5 age range, you've just bought yourself 70 years of health problems. So very strong focus in Alaska on that, building efficacy, health, and a whole mindset about will and resiliency in the 0 to 5 population, and it's just amazing. And then finally, I'll wrap up with Bellin in Green Bay, Wisconsin. At Bellin, they looked at the flow faults work, they looked at the triple aim. It's a hospital system, but what they said is they found often patients were in a more expensive spot than they needed to be. So they created what they call the access pyramid, and they said, first of all, every patient in our community should have their own health record. And then second, if they have a question, they should have a 24-hour telephone line that they can access information. And then they gradually move the patient through the pyramid to the most expensive care settings. But the patient has the easiest access to the care they want to need in the place they want to need it. They had a little bit of trouble getting everybody in the community on board first, so they took their workforce as the test bed, and they improved their health risk appraisal scores dramatically. They focused on only the people in the beginning who worked at Bellin Health. They decreased the high-risk employees dramatically, and as they did that, they lowered their employee health costs by 33%. So in essence, in the last 5 years, the employees have not had any increases in their health insurance premiums, which the employees see as they're getting a raise in pay. They also calculated that if we could get every hospital in the country to adapt and adopt this kind of a focus on the health care of your workforce, we could save $63 billion. And what happened was, as their workforce started to get more vital, and they were driving down their own insurance costs, 42 companies in the community have come now to Bellin and said, can you come and do that to our employees? Can you help us to improve health in this way? So in essence, Bellin joining the Triple Aim project, focusing on their own workforce first, has created a tremendous market advantage. And all of a sudden now people are coming and saying, I see how the health and the vitality of the workforce is improving your business. I see presenteeism and engagement at work is improving, and I see costs going down. Win, win, win. Can I buy into that? So I think the Triple Aim is going to be the way forward. I commend you on the new collaboration, but it will take courage, because a lot of our models are going to change. It's going to need innovation. It's going to need collaboration. It's going to need a real dedication. Most of all, it's going to take a new way to listen to patients that we haven't really done effectively and completely before. But I'm convinced that the more progress we can make here in South Carolina on adopting the Triple Aim at a statewide level, I truly do believe what Jim said earlier, that is, you can show the way. We can show the rest of the country that healthcare reform can happen from the states up and not from the government down. So thank you for your courage. Thank you for your enthusiasm and your commitment to patient safety, and for all you're doing to adopt the Triple Aim. Everybody at IH High is so delighted and very grateful to you.